Welcome back to the deep dive. Today we're getting into something really critical. We're talking about mastering the complications of the third stage of labor. It's arguably the most dangerous time in the whole process.
That's absolutely right. If you really want to excel in this field, you have to grasp that this period, the third stage between the baby being born and the placenta coming out, it's just the most crucial point for the mother.
Yeah, the first two stages could go perfectly.
Exactly. Textbook, perfect. But then suddenly you can face these potentially fatal complications, especially hemorrhage, and they can appear out of nowhere and escalate incredibly fast.
That speed is what's so frightening, isn't it? The window to actually do something effectively feels agonizingly short.
It is. So our mission today is really to break down the source material, get into those detailed elite-level management protocols. We want you, the listener, to feel prepared for, well, pretty much any contingency.
We're focusing on that whole continuum of care, understanding what it takes to save a life when literally seconds count.
Right. And to structure this, we've looked at the source material and organized it around what we're calling the big five complications. These are the ones that really dominate this stage.
Okay, what are the big five?
First, postpartum hemorrhage, PPH. That's the main one. Then, retention of the placenta. Third is shock, could be hemorrhagic, could be non-hemorrhagic.
Right.
Fourth, pulmonary embolism, which might be from amniotic fluid or even air. And finally, the really rare one, but devastating when it happens, uterine inversion.
Okay, let's definitely start with the heavy hitter then. Postpartum hemorrhage, PPH. It's the single biggest cause of maternal death and illness worldwide, isn't it?
It is. And to manage it, you first have to be absolutely clear on the definition. And here's where things get interesting, because there's a bit of a necessary split between how we define it for statistics versus clinical reality.
Okay, so there are two definitions.
That's right. Both are important, but for different reasons. First, you've got the quantitative definition. This is mostly for tracking, for public health statistics.
The numbers game.
Pretty much. It's defined as, well, an arbitrary blood loss over 500 milliliters after a vaginal delivery, or over 1,000 milliliters after a cesarean. The World Health Organization uses that 500 milliliter mark as the sort of universal benchmark.
But that's not the one you use when you're actually facing the situation, right?
Exactly. The really practical, actionable definition is the clinical definition. And this says PPH is any amount of bleeding that starts to adversely affect the patient's general condition.
So it's not about hitting a specific number.
It's about the effect. That's the key. You're looking at the patient's physiology, how they're responding. Are you seeing that pulse rate climbing? Is the blood pressure starting to fall?
That makes sense. The effect, the shock state developing, that's more critical than arguing about whether it was 450 or 550 milliliters lost.
Precisely. And this focus on the clinical picture is vital because, as the Royal College of Obstetricians and Gynecologists, the RCOG, pointed out back in 2016, visually estimating blood loss, it's just notoriously inaccurate.
We tend to underestimate, don't we? Especially when it's mixed with fluid or hidden.
Massively underestimate, sometimes by 50% or more. So just relying on a visual volume estimate is, frankly, a potential failure in clinical practice. You have to include the signs and symptoms.
Okay, so if we can't always trust visual estimates, what are the sort of average expected losses, just for context?
Well, for a standard vaginal delivery, the average is around 500 milliliters. For a cesarean, it jumps to about 1,000 milliliters.
Okay.
And if you're dealing with the most complex scenarios, say a cesarean hysterectomy, the average benchmark loss is around 1,500 milliliters.
Knowing those averages helps frame the severity grading, I suppose. How is PPH graded?
It's based on volume, but with the understanding that clinical effect is paramount. Minor PPH is generally less than 1 liter, often manageable locally.
Okay.
Major PPH is defined as greater than 1 liter. Now you need serious resources mobilized. And severe PPH is blood loss greater than 2 liters. That's catastrophic, demanding immediate, all-hands-on-deck, multidisciplinary intervention.
And there's also a classification based on timing, isn't there? Primary versus secondary.
Correct. Primary PPH is bleeding that happens within the first 24 hours after birth. And actually, the vast majority, something like 70%, occurs within the first 2 hours.
So right after delivery, basically.
Yes. And within primary PPH, you can further break it down. There's third-stage hemorrhage, which is bleeding before the placenta is out, and then true postpartum hemorrhage, which is bleeding after the placenta is delivered. That's the majority of primary cases.
And secondary PPH.
There's the delayed or late kind. It happens after that initial 24-hour window, anytime during the pure period, the postpartum period. It often points to a different cause, like retained tissue or maybe an infection.
Got it. So that framework helps categorize it. Now let's dig into why primary PPH happens. The etiology. You mentioned the archaeology framework, the 4 T's.
Yes, the 4 T's. It's a really elegant and practical way to think through the potential causes, especially when you're under pressure. It ensures you cover the bases.
What are they again?
Tone, meaning uterine atonicity. The uterus isn't contracting properly. Tissue, meaning retained bits of placenta or clots. Trauma injury to the genital tract. And thrombin problems with blood clotting, coagulopathy.
Let's start with tone then. You said it's the most common.
By far. A tonic uterus accounts for about 80% of all primary PPH cases. It's the overwhelming cause, so it demands your immediate attention.
Can you explain the mechanism? How does a floppy uterus lead to such significant bleeding?
It's actually quite straightforward physiology. Once the placenta separates from the uterine wall, it leaves behind these open, torn blood vessels, the uterine sinuses. They're quite large.
Okay.
The only way the body naturally stops bleeding from those sinuses is through powerful contraction and retraction of the uterine muscle. The muscle fibers literally act like living ligatures, clamping down on those vessels. When the uterus is atonic, meaning it's flabby, tired, lacking tone, those living ligatures just fail. They don't clamp down effectively, and you get rapid, often massive hemorrhage.
And what makes a uterus become atonic? The risk factors must be numerous.
They are extensive. The sources break them down into several categories. Basically, anything that overstretches the uterus, exhausts it, or interferes with its ability to contract properly.
Let's go through them. What about uterine size or history?
Okay, first, think about the grand multipara, a woman who's had 5 or more previous births. The uterine muscle might just be tired, less responsive.
Makes sense.
Then, overdistension is a huge factor. If the uterus has been stretched excessively, like with twins or multiple pregnancies, or hydramnios, too much amniotic fluid, or even just a really big baby, say, over 4 kilograms.
That stretched muscle struggles to clamp down afterwards?
Exactly. Then you have pre-existing conditions affecting the mother's overall health.
Like what?
Malnutrition and significant anemia, especially if her hemoglobin before delivery is less than 9.0 grams per deciliter. She starts off with less reserve to tolerate blood loss.
Right.
Also, a history of antepartum hemorrhage, bleeding before labor, whether from placenta previa or placental abruption, is a known risk factor for PPH later.
What about the labor itself, the delivery dynamics?
Both extremes are risky. Prolonged labor, often defined as over 12 hours, can lead to uterine muscle fatigue. The muscle is just exhausted by the time it needs to contract after delivery.
And the opposite, very fast labor.
Yes. Precipitate labor, extremely rapid delivery is also a risk factor. The muscle fibers might not have had time to adapt and coordinate properly for effective contraction afterwards.
The sources also really highlighted a mismanaged third stage. What does that mean exactly? Why is fiddling with the uterus or cord bad?
This refers to technical errors. Trying to rush the placenta out before it's fully separated. Maybe kneading the uterus too aggressively or pulling on the umbilical cord too early or too hard.
Why is that bad?
It can cause irregular contractions or even partial separation of the placenta. This leaves those large uterine sinuses exposed and bleeding, but without the necessary full, coordinated uterine contraction to clamp them shut. It's often an error born of impatience.
Okay, that's a critical point. What about medical interventions? Anesthesia.
Yes, certain types of general anesthesia, especially older agents like ether or halothane, cause general muscle relaxation, and that includes the uterus.
And oxytocin, isn't that used to cause contractions?
It is, but it's a bit of a double-edged sword. If labor was started or boosted with an oxytocin infusion, that uterus might be used to the external stimulus and become exhausted or less responsive afterwards.
Aha! So you need to keep it going.
Absolutely. That's why the recommendation is to continue the oxytocin infusion for at least an hour after delivery in those cases. Also, if tocolytic drugs were used earlier in the pregnancy to stop contractions, drugs like ritodrine, magnesium sulfate, nifedipine, they can linger and interfere with the uterus contracting strongly after birth.
Right, makes sense. And finally, anatomical or pathological issues.
Yes, things like congenital malformations of the uterus like a septum or a bicornuate uterus can mechanically prevent uniform contraction. Uterine fibroids can do the same, creating sort of a dead space.
And the big one.
The really critical one here is morbidly adherent placenta accreta, increta, or percreta, where the placenta is abnormally attached. Or simply any retained placental fragments, or a partially separated placenta. These physically stop the uterus from clamping down.
Okay, that covers tone comprehensively. Let's move to the second T, trauma. Accounts for about 20%.
Roughly, yes. And importantly, this requires a different mindset because typically with traumatic bleeding, the uterus itself is firm and well contracted. The bleeding is coming from somewhere else.
Where does this trauma usually occur?
It often follows an operative delivery forceps, vacuum extraction, or a cesarean section. But it can absolutely happen after a spontaneous delivery too. Common sites are lacerations of the cervix, the vagina, or the perineum, especially around an episiotomy or tears, sometimes the periurethral area, and rarely, but catastrophically, uterine rupture.
You mentioned something earlier about underestimating blood loss from tears or episiotomies.
Yes, the sources emphasize this. It's easy to focus on the uterus and sort of ignore or underestimate the blood loss from, say, an extensive episiotomy or perineal tear. You could easily lose 800 to 1,000 milliliters just from that site.
And if that's happening alongside some uterine bleeding.
It pushes the patient into major PPH territory very quickly. Also, remember the possibility of concealed bleeding from trauma.
Ah, the hematoma.
Exactly. A vulvovaginal hematoma, or one expanding into the broad ligament. The blood loss isn't visible externally, it's accumulating internally, but the patient is still developing shock. That can be incredibly deceptive.
Okay. The third T was tissue.
Tissue. This is perhaps the simplest cause, conceptually. Retained bits of the placenta or even large blood clots remaining inside the uterus act like foreign bodies. They physically prevent the uterine walls from coming together and contracting perfectly to stop the bleeding.
Makes sense. The uterus can't clamp down fully if something's in the way.
Precisely.
And the final T, thrombin. Coagulation problems. You said these are rare.
They are much less common as a primary cause, but they can be devastating. It means the blood itself isn't clotting properly. This might be because the clotting factors are depleted, sometimes called the washout phenomenon.
What's the washout phenomenon?
It can happen during massive hemorrhage resuscitation. If you're pouring in large volumes of crystalloid fluids or plasma extenders very quickly, you can actually dilute the patient's own clotting factors, literally washing them out.
So the treatment itself can worsen the problem.
In a way, yes, it's an iatrogenic contribution, exacerbated by the underlying massive blood loss, which also consumes factors. Or the coagulopathy could be due to increased fibrinolytic activity, the body breaking down clots too quickly.
Are there specific conditions associated with thrombin issues?
Yes, they often occur in the context of other severe obstetric conditions like abruptio placentae, severe preeclampsia, HELLP syndrome, that's hemolysis, elevated liver enzymes, low platelet count, or sometimes following an intrauterine death. Conditions like jaundice in pregnancy or thrombocytopenic purpura can also predispose.
And treatment for this specific T?
It really requires identifying the specific defect through a coagulation screen and targeted replacement therapy, things like fresh frozen plasma, cryoprecipitate, platelets. The source material does mention using recombinant activated factor 7, often called RFVIA, as a sort of last-ditch agent for refractory bleeding when other measures fail. But its routine use isn't typically recommended first line.
Okay, that's a lot of potential causes. Tone, tissue, trauma, thrombin. Given this variety, how does the clinician on the ground quickly figure out what they're dealing with? This moves us into diagnosis and, crucially, advanced clinical assessment.
Right. Diagnosis might seem obvious. You see bleeding. Sometimes it's that slow, steady trickle. Other times a sudden gush. But always keep in the back of your mind that rare, totally concealed hematoma.
So focus on the clinical effect again.
Absolutely. The effect of the blood loss is determined by three main things. First, the patient's pre-delivery hemoglobin level. What was her starting point, her reserve? Second, the degree of pregnancy-induced hypervolemia. Pregnant women naturally have more blood volume, which can initially compensate and mask the early signs of significant loss.
Right, that buffer effect.
Exactly. And third, and perhaps most critical, is the speed of the blood loss. Losing 1,500 milliliters slowly over several hours is very different physiologically than losing 1,000 milliliters rapidly in 15 minutes.
And the standard vital signs, like blood pressure, they lag behind, don't they?
That's a vital point. You often don't see significant changes in pulse and blood pressure until the patient has already lost 20 to 25% of their total blood volume. That's class 2 hemorrhage. Relying solely on blood pressure as your first alert is waiting too long.
So what do you rely on initially? Palpation.
Palpation is key for differentiation. Feel the uterus. If it's firm, well contracted, sitting like a hard cricket ball below the umbilicus, but there's still significant bleeding, think trauma. Look for a tear.
And if it's soft?
If the uterus feels flabby, boggy, maybe firms up a bit when you massage it, but then relaxes again. That's your classic atonic uterus. That's tone failure. But remember, the two can coexist. Massive trauma can lead to shock, which can then lead to secondary atonicity.
Because of this lag in vital signs, the sources emphasize more advanced, earlier assessment tools for the, quote, elite professional. Let's talk about the Rule of 30.
Yes, the Rule of 30 is a useful clinical bundle. It's a set of 5 signs that, when present, strongly indicate the patient has likely lost at least 30% of their blood volume and is in moderate to severe shock. It's a threshold indicator.
What are the 5 signs?
Okay. 1, a fall in systolic blood pressure, SBP, by 30 millimeters of mercury or more. 2, a rise in heart rate by 30 beats per minute or more. 3, a rise in respiratory rate to over 30 breaths per minute.
Got it.
4, a drop in hemoglobin or hematocrit by 30%. Though be aware, this is often a late indicator, as it takes time for fluid shifts to reflect the change. And 5, a fall in urine output to less than 30 milliliters per hour. If you're seeing these, you're definitely behind the curve and need immediate aggressive action.
So the Rule of 30 signals a significant crisis point, but is there something even earlier? You mentioned the shock index.
Yes, the shock index, or SI. This is a really valuable, simple tool because it combines 2 vital signs into a ratio that can show changes before either sign becomes dramatically abnormal on its own.
How is it calculated?
It's simply heart rate divided by systolic blood pressure. Normally, in a healthy adult, it's around 0.5 to 0.7.
Okay.
When acute hemorrhage starts, the body's first compensation is often to increase the heart rate, even while the blood pressure is still relatively maintained. So the heart rate goes up, the SBP hasn't dropped much yet, and that ratio, the SI, starts to climb.
So the ratio changes before the BP tanks.
Exactly. In major hemorrhage, the shock index often rises to 0.9 to 1.1 or even higher. The sources really stress that monitoring the trend of the shock index can give you a much earlier warning of significant bleeding than just looking at pulse or BP in isolation.
That's a fantastic clinical pearl. Let's shift gears slightly to prognosis. We know PPH is a major killer globally, but what about the survivors? What are the potential long-term consequences or morbidities?
Well, beyond the immediate risks of hemorrhagic shock itself, needing transfusions which carry their own risks, there's significant associated morbidity. Puerperal sepsis or infection is a risk.
Okay.
Failing lactation can occur. There's an increased risk of thromboembolic events, pulmonary embolism, or deep vein thrombosis associated with the hemorrhage, the immobility, and sometimes the transfusions.
And the sources mentioned some severe, rarer, late effects. Sheehan syndrome.
Yes, Sheehan syndrome. It's a rare but devastating long-term consequence. It's essentially selective hypopituitarism damage to the pituitary gland, caused by ischemic necrosis. During severe PPH and profound shock, the blood supply to the pituitary gland, which is very metabolically active, can be compromised. The resulting damage leads to a deficiency in pituitary hormones.
What does that look like clinically, long-term?
Initially, it might present as failure to lactate postpartum or amenorrhea, loss of periods. Later, you can see failure of other endocrine systems regulated by the pituitary, like thyroid and adrenal insufficiency. It's a lifelong condition. Very rarely, severe PPH can also damage the posterior pituitary, causing diabetes insipidus.
Truly devastating consequences, which underscores the critical importance of prevention. Now, the sources made a crucial point. Many PPH cases occur without any identifiable risk factors.
That's right. You can't always predict it. It can strike unexpectedly, even in a low-risk patient. But while we can't eliminate the risk entirely, effective prevention strategies can significantly reduce the magnitude and incidence of PPH.
So what does prevention look like? Antenatal measures first.
Antenatally, the main goal is to optimize the patient's health and identify high-risk individuals. This means improving nutritional status, treating anemia to get that hemoglobin ideally above 10 grams per deciliter before delivery.
Building reserve.
Exactly. And screening actively for those known high-risk factors. Twins, hydramnios, grand multiparity, history of APH or previous PPH. These women should be booked for delivery in a well-equipped hospital.
What about blood grouping?
Absolutely essential. Every pregnant woman should have blood grouping done. And critically for women with previous C-sections, placental localization using ultrasound or sometimes MRI is vital.
Why specifically for previous C-sections?
To look for morbidly adherent placenta accreta, the risk increases dramatically with each prior cesarean, especially if there's also placenta previa. Finding accreta antenatally changes everything. It requires planning, a multidisciplinary team, having blood products ready before delivery.
That makes sense. Now, intranatally during labor and delivery, what's the cornerstone of prevention?
The single most effective intervention, according to the sources, is active management of the third stage of labor, or AMTSL. This should be offered to all women.
How effective is it?
It reduces the incidence of PPH by about 60%. It's huge.
Wow. What does AMTSL involve?
It typically involves three components: giving a uterotonic drug like oxytocin just as or after the baby's anterior shoulder is delivered, performing controlled cord traction to help deliver the placenta once signs of separation appear, and massaging the uterus after the placenta is out to ensure it contracts well.
Okay. What about specific drug prophylaxis in high-risk situations, like an induction or C-section?
If labor was induced or augmented with oxytocin, you must continue that infusion for at least 1 hour after delivery to prevent rebound athenate. For all cesarean sections, the recommendation is a bolus of oxytocin, typically 5 international units given slowly intravenously. Or sometimes carbetocin is used. It's a longer-acting synthetic oxytocin analog given as 100 micrograms 4 feet.
And after the delivery is complete, post-delivery care.
Vigilance is key. Careful observation for at least 2 hours in the delivery or recovery area. Keep checking that the uterus remains firm and well contracted.
Anything else?
After any difficult labor or instrumental delivery, you should routinely explore the uterus and vaginal canal to check for trauma, for tears. Also, where possible, favoring regional anesthesia like epidural or spinal over general anesthesia can help, as general anesthesia relaxes the uterus.
One more point from the sources on C-sections allowing spontaneous separation of the placenta.
Yes, rather than manually removing it immediately unless necessary. Allowing it to separate spontaneously might reduce blood loss. The bottom line from all the sources is clear. Disaster in the third stage is prevented by intelligent anticipation, skilled supervision, prompt detection of problems, and the effective, rapid institution of therapy.
That perfectly sets up our next section, the detailed management protocols. When major PPH hits more than a liter lost or signs of clinical shock, we enter the golden hour. You said this isn't sequential, it's simultaneous.
Absolutely. Think of it as a coordinated, multi-pronged attack on the problem. The golden hour concept emphasizes that the patient's chances of survival plummet if effective resuscitation and control of bleeding aren't achieved within roughly the first hour.
What are the core objectives during this golden hour?
There are three, happening all at once. 1, empty the uterus if needed and make it contract. Stop the source of its athenate. 2, replace lost blood volume and aggressively manage the shock. 3, if the bleeding is traumatic, achieve effective hemostasis, stop the bleeding from the injury.
Okay, let's break down the immediate resuscitation steps. This is like step 0, the moment the alarm bells ring.
First, communication and staff. Shout for help. This is absolutely a team sport. Get experienced help, immediately call the senior obstetrician, call the anesthetist, alert the blood bank.
Okay, get the team activated. What's next?
Vascular access and diagnostics. This is critical. Insert 2 large-bore intravenous cannulas. The sources specify 14 gauge if possible.
Why 14 gauge specifically? Is the size that important?
It's physics. Poiseuille's law tells us flow rate is proportional to the radius to the 4th power. A 14-gauge cannula allows you to infuse fluids orders of magnitude faster than a smaller 18 or 20-gauge line. When you need to get liters of fluid in rapidly, bore size is absolutely critical.
Got it. Big pipes or fast flow. What about blood tests?
As you're putting the lines in, draw blood simultaneously. Send it urgently for a full blood count, coagulation screen, including fibrinogen, renal and liver function tests, and crucially, group and cross-match. Tell the blood bank you anticipate needing blood, urgently request at least 2 units, maybe more depending on the situation. Be prepared immediately.
Lines in, blood sent. Next is fluid resuscitation.
Yes. Volume expansion. Start rapid infusion of crystalloid solution, normal saline or Ringer's lactate. Aim for about 2 liters initially, given as fast as possible.
Yeah.
Or use plasma substitutes, colloids like Hamatel, if available and indicated.
And supportive care.
Oxygen. High-flow oxygen. 10 to 15 liters per minute via a mask with a reservoir bag. And Foley catheterization. Insert a catheter to monitor urine output accurately and continuously. It also empties the bladder, which helps the uterus contract.
The sources mentioned something about assigning specific monitoring tasks.
Yes, this reflects elite-level organization in a crisis. Assign specific team members to continuously monitor and record 8 key variables.
8 variables? That sounds intense. What are they?
Pulse rate, blood pressure, temperature, respiratory rate, and oxygen saturation, oximetry. Those are the standard vitals. Then fluids track exactly what type and how much is going in. Urine output measured hourly via the catheter, a critical indicator of organ perfusion. Drugs record every drug given, the dose, the time. And finally, if the shock is severe, central venous pressure, CVP monitoring might be initiated by the anesthesia team.
That continuous, focused monitoring must be essential for guiding ongoing treatment.
It absolutely is. It tells you if your resuscitation is working and what needs to happen next, moment by moment.
Alongside resuscitation, there are specific therapeutic goals, right? Objective targets the team is aiming for.
Yes, these are the physiological benchmarks that indicate stabilization. You're aiming for a hemoglobin level consistently above 8 grams per deciliter, a platelet count above 50 times 10 to the power of 9 per liter.
Okay.
Fibrinogen level above 2 grams per liter fibrinogen is crucial for stable clot formation. And coagulation times, the activated partial thromboplastin time, APTT, and prothrombin time, PT, ideally less than 1.5 times the normal laboratory control value.
And if blood is needed right now, before cross-matching is complete.
In a true life-threatening emergency, you use Group O RHD negative blood, sometimes referred to as the universal donor type, ideally K negative as well, if available rapidly. This minimizes the risk of a major transfusion reaction when there's no time to wait.
Okay, resuscitation is underway, turrets are set. Now, let's get into the specific steps to actually stop the bleeding, focusing first on atonic bleeding, the most common cause. The sources lay out a stepwise approach. Step I.
Step I is pharmacological and mechanical control. First, get your hands on the uterus, palpate the fundus through the abdomen, massage it firmly to stimulate contraction, and expel any clots that might be inside.
So massage first.
Right.
And drugs simultaneously.
Yes, start an intravenous infusion of crystalloid solution containing oxytocin. A common regimen is 20 units of oxytocin in 1 liter of fluid, run in rapidly initially, maybe 60 drops per minute or faster, depending on the pump. Also give an additional bolus of uterotonic, either oxytocin 10 units intramuscularly or ergometrin, methergine, 0.2 or even 0.5 milligrams, usually given slowly intravenously or intramuscularly.
What's ergometrin or methergine again?
It's an ergot alkaloid. Causes a very strong sustained uterine contraction. Highly effective for ADNI, but you have to be cautious. It can cause significant hypertension, so it's generally contraindicated in women with preeclampsia or high blood pressure.
Okay. Massage, oxytocin infusion, another uterotonic bolus. What else in step I?
Make sure the bladder is empty. Use that Foley catheter. A full bladder physically impedes uterine contraction. And consider giving prophylactic antibiotics like ampicillin and metronidazole because the risk of infection increases with uterine manipulation and hemorrhage.
There was a crucial diagnostic check mentioned here. If you do all that massage, give drugs, and the uterus does become firm but the bleeding continues, what does that tell you?
That's the key differentiator. If the uterus is hard, well rubbed is the old term, but bleeding persists, it strongly suggests the primary problem isn't tone anymore. It's likely trauma, a cervical tear, a vaginal laceration, maybe even that concealed hematoma. You need to stop focusing solely on the uterus and immediately start a systematic examination of the entire genital tract to find the source of the traumatic bleeding.
Okay. But if the uterus doesn't firm up with step I measures, if it stays flabby and bleeding continues, we move to step 2.
Correct. Step 2 is escalated pharmacological management for these refractory cases. Often this step is best done in an operating theater setting, possibly under general anesthesia, as you'll likely need to explore the uterus internally anyway to rule out retained tissue, the T's for tissue.
What drugs are added in step 2?
We bring in the prostaglandins. The main one is often intramuscular carboprost, which is 15-methylprostaglandin F2 alpha. The dose is typically 250 micrograms, given deep intramuscularly, and can be repeated every 15 minutes up to a maximum total dose of 2 milligrams, so 8 doses maximum. It's very potent, but can have side effects like bronchospasm, caution in asthmatics, nausea, vomiting, diarrhea, and temperature elevation.
Is there an alternative prostaglandin?
Yes, misoprostol, which is a prostaglandin E1 analog, it's also very effective, especially given rectally. A common dose is 800 to 1,000 micrograms administered per rectum. It tends to have fewer systemic side effects than carboprost.
The sources also mentioned adding tranexamic acid.
Yes. If not already given, add tranexamic acid. Typically 1 gram given intravenously, slowly. It's an antifibrinolytic. It helps stabilize clots that are forming by preventing their premature breakdown. It's been shown to reduce mortality in PPH.
And that point about calcium blockers.
Right, a specific situation.
Yeah.
If you suspect the atony might be due to or worsened by prior administration of tocolytic drugs like nifedipine, a calcium channel blocker, or magnesium sulfate, then giving calcium gluconate, 1 gram, slowly intravenously, can help counteract their relaxing effect on the uterine muscle.
Okay, so step 2 is more potent drugs, often in theater. If that still doesn't work and the uterus remains atonic, what's step 3?
Step 3 is direct mechanical compression,
Uh-huh.
bimanual uterine compression. This is a physical, hands-on technique to try and stop the bleeding.
Can you describe how it's done? It sounds quite invasive.
It is, and requires appropriate pain relief or anesthesia.
Huh.
The operator inserts one hand, usually gloved, fully into the vagina. You clench that hand into a fist. The back of the fist is directed posteriorly towards the patient's back, and the knuckles are pushed up firmly into the anterior vaginal fornix, right under the cervix.
So one hand inside, pushing up.
Yes, the other hand is placed on the patient's abdomen, behind the uterine fundus. You then use that external hand to press the posterior aspect of the uterus firmly down and forward, anteverting it against the internal fist.
So you're literally squeezing the uterus between your two hands.
Exactly. You're applying direct, firm, sustained compression to the bleeding surfaces. This needs to be maintained continuously until the uterus regains tone and the bleeding stops, which might take several minutes or longer. You periodically check by slightly releasing pressure.
If even direct bimanual compression fails, we're moving into more invasive territory. Step 4 is uterine tamponade.
Yes, if pharmacological measures and direct compression haven't worked, the next logical step is usually to tamponade the uterus from the inside. This is often considered the first-line surgical or procedural intervention before considering more drastic surgery.
The sources mention 2 main ways, packing and balloons. Let's start with the traditional one, packing.
Right. Intrauterine packing used to be more common. It involves taking a long, sterile gauze roll, often 5 meters or more, and systematically packing it tightly into the uterine cavity. You start right up at the fundus and pack downwards, filling the entire cavity.
How does that work?
It works in 2 ways. The physical presence of the pack stimulates the uterus to contract around it, and the tightly packed gauze applies direct pressure to the bleeding surfaces, the open sinuses.
But you said it's less common now. Why the shift to balloons?
Balloons, like the Bakri balloon, or even adapting a large Foley catheter or a Sengstake and Blakemore tube, have largely replaced packing in many centers. They are generally quicker and easier to insert correctly, ensure more uniform pressure, are easier to monitor for ongoing bleeding, often have a drainage port, and importantly, easier and less traumatic to remove. There's also potentially less risk of concealed bleeding behind a pack or retained fragments of gauze.
How do the balloons work?
You insert the deflated balloon into the uterine cavity, position it correctly, and then inflate it with sterile, normal saline. The volume varies depending on the device and uterine size, typically 200 to 500 milliliters. The inflated balloon exerts direct hydrostatic pressure against the uterine walls.
And how successful is balloon tamponade?
It's reported to be highly successful. The sources quote success rates around 78% or even higher in avoiding the need for hysterectomy in cases of refractory atonic PPH. It's a really important tool in the armamentarium.
Are there any other temporary measures mentioned around this stage?
Yes, a couple of things. The non-pneumatic anti-shock garment, NASG, it looks like a wetsuit for the lower body can be applied. It provides circumferential pressure to the legs and abdomen, reducing pelvic blood flow and potentially improving central circulation. It's mainly used as a temporary measure, especially during transport, if the patient needs to be moved to a higher level of care. And in dire emergencies, temporary manual compression of the abdominal aorta against the spine can dramatically reduce pelvic blood flow, buying precious time while other interventions are prepared or resuscitation catches up.
Right, desperate measures for desperate times. If tamponade fails or isn't appropriate, we reach step V, surgical devascularization. This sounds serious.
It is. This involves surgically ligating, tying off the arteries, supplying blood to the uterus. It's usually done in a stepwise fashion, starting with the most accessible vessels and progressing if bleeding continues.
What's the first surgical step typically?
Often it starts with uterine compression sutures. The most famous is the B-Lynch suture.
How does that work?
It involves placing large, absorbable sutures that go around and compress the uterus, essentially acting like an internal brace or strap. It physically squeezes the uterus to stop bleeding from the muscle wall. It's quite effective, with reported success rates around 80%, and it preserves the uterus. There are variations, like multiple square sutures.
Okay, so sutures first, if that doesn't control it.
Then you move to vessel ligation. The next step is usually bilateral uterine artery ligation. The surgeon identifies and ties off the main ascending branch of the uterine artery on both sides, where it runs alongside the uterus. This significantly reduces blood flow to the main body of the uterus. It's effective in about 75% of refractory atonic cases.
And if that fails?
The bleeding might be coming from collateral supply, often from the ovarian arteries. So the next step could be ligation of the uteroovarian anastomosis, tying off the vessels where the uterine and ovarian arteries connect, higher up near the fallopian tubes.
Still bleeding. What's next? This feels like a ladder of escalation.
It is. The next major step up is ligation of the internal iliac artery, specifically the anterior division. This can be done unilaterally or bilaterally. It's a more complex procedure, requiring dissection deep in the pelvis.
Why leg the internal iliac? Doesn't that cut off blood supply to the whole pelvis?
Not entirely. Tying the anterior division significantly reduces blood flow and, crucially, the pulse pressure in the downstream arteries, including the uterine artery, by up to 85%. This reduction in pressure allows clots to form more easily at the bleeding sites within the uterus. It doesn't cause pelvic tissue necrosis because there's extensive collateral circulation from other vessels like the lumbar, middle sacral, and gluteal arteries.
How effective is internal iliac ligation?
It can be very effective, potentially avoiding hysterectomy in about 50% of the cases where it's employed for refractory hemorrhage.
Is there a non-surgical alternative to these ligations if the facility has the capability?
Yes. Angiographic selective arterial embolization. This is done by interventional radiologists. They access the femoral artery, guide a catheter up to the bleeding pelvic vessels under fluoroscopic guidance, and then inject tiny particles like gel foam or coils to block, embolize the specific arteries feeding the hemorrhage.
And its success rate?
It's very high, often reported as over 90%. It's minimally invasive compared to open surgery and preserves the uterus. If available and the patient is stable enough for transfer to the radiology suite, it's often the preferred method for refractory bleeding after tamponade fails.
So we've gone through drugs, compression, tamponade, sutures, ligation, embolization. If absolutely nothing else works, we arrive at step 6.
Step 6. Hysterectomy, the surgical removal of the uterus. This is the definitive treatment to stop uterine bleeding, but obviously it means loss of fertility. The sources emphasize that the decision for hysterectomy shouldn't be delayed too long if other measures are clearly failing, especially in a woman who has completed her family. Delay increases morbidity and mortality. Ideally, the decision involves consultation with the second senior clinician.
That's a sobering endpoint. We focus heavily on atonic PPH. What if the cause was identified early on as traumatic?
If the uterus is firm but bleeding persists, the management shifts entirely away from uterotonics and focuses on surgical repair. You need good lighting, good exposure, often using retractors or speculums, and usually anesthesia. Systematically inspect the cervix, vagina, perineum, and vulva to identify the source, the laceration or tear. Once found, it needs to be repaired meticulously with appropriate sutures to achieve hemostasis. Sometimes a deep cervical or vaginal tear requires significant skill to repair properly.
Okay, let's touch briefly on secondary PPH, the delayed bleeding. What causes that typically?
Secondary PPH, remember, occurs after 24 hours, often around day 8 to 14 postpartum. The most common cause by far is retained placental fragments or membranes.
Bits left behind.
Exactly. Other causes include infection, like endometritis, which can erode blood vessels, or sometimes the sloughing, breaking down of tissue over a deep laceration that was previously repaired.
How does it present?
Often with sudden bright red, sometimes quite brisk bleeding, often accompanied by signs of uterine infection like fever, pain, and foul-smelling lochia. Anemia is common. Ultrasound is key here to look for retained products within the uterine cavity.
And management. Is it conservative?
No, definitely not. Secondary PPH requires active management. The standard approach is admission, stabilization if needed, antibiotics, and then exploration of the uterus under general anesthesia. You need to remove any retained products, usually using ovum forceps and perhaps gentle curettage, often with a suction or flushing curette, to minimize trauma to the recently pregnant uterus.
The sources had a strong warning here.
Yes. Never ignore even slight bleeding occurring in the late postpartum period. It could be the prelude to a sudden, massive, alarming hemorrhage when that retained piece finally separates completely. Prompt investigation and treatment are essential.
Okay, that covers PPH extensively. Let's move to the second major complication. Retained placenta. How is that defined?
The standard definition is failure of the placenta to be expelled within 30 minutes after the birth of the baby. Some guidelines, like WHO, use a shorter interval like 15 minutes, especially if active management was used.
What causes the placenta to get stuck?
It's usually an interference with one of the 3 normal phases of the third stage: placental separation from the uterine wall, descent into the lower segment or vagina, or expulsion from the vagina.
And the specific reasons.
The sources categorize them. 1, the placenta might be completely separated but just retained within the uterus, perhaps due to insufficient uterine contractions or poor maternal effort. 2, it could be simple adherence, often linked to uterine atonicity. The uterus isn't contracting strongly enough to shear it off.
Okay.
3, the really problematic one, morbidly adherent placenta accreta spectrum, where it's abnormally fused to the uterine wall. Or 4, it could be incarcerated, meaning the placenta is separated but trapped above a constricted lower uterine segment or cervix, sometimes called an hourglass contraction.
If the placenta is retained beyond that 30-minute mark, what's the management?
The standard procedure is manual removal of placenta, or MRP. This absolutely requires anesthesia, usually general or effective regional anesthesia, because it's very painful and can induce shock.
The sources detailed 7 specific steps for MRP. Can you walk us through those?
Sure. Step 1. Preparation. Get the patient in the lithotomy position, legs in stirrups. Ensure good lighting. Maintain strict asepsis, sterile technique. Step 2. Introduction of the hand. The operator, wearing a sterile long cuff glove, forms their hand into a cone shape and gently introduces it into the vagina, following the umbilical cord up into the uterine cavity to locate the placenta.
Following the cord like a guide rope.
Exactly. Step 3. Counterpressure. Crucially, the operator's other hand is placed firmly on the abdomen over the uterine fundus. This steadies the uterus and provides counterpressure, which is vital to prevent accidentally inverting the uterus during the internal manipulation.
Okay, hand inside, counterpressure outside. Step 4 is the actual separation.
Yes. Once the edge of the placenta is found, the fingers are carefully insinuated between the placental tissue and the uterine wall into the plane of cleavage. The separation is then performed using gentle, sideways slicing or shearing movements, with the side of the fingers keeping the back of the hand against the uterine wall to minimize trauma. You continue this carefully until the entire placenta is detached.
Gentle but firm. What's step 5?
Extraction. Once the placenta is fully separated, you grasp it firmly with the internal hand and gently withdraw it from the uterus, possibly aided by slight cord traction from an assistant. The internal hand should remain inside briefly to ensure the cavity feels empty and there are no large remaining fragments.
Step 6 involves medication and checking.
Right. As the placenta is being removed or immediately after, an intravenous uterotonic drug, like oxytocin or ergometrine, is given to ensure the uterus contracts firmly now that it's empty. The internal hand is then slowly withdrawn, while the external hand continues to massage the fundus to confirm good tone. You should also quickly inspect the cervix and vagina for any lacerations caused during the procedure. And the final step, step 7.
Final inspection. Once the placenta is out, it must be meticulously examined on a flat surface to check for completeness. Ensure all the cotyledons, lobes are present, and the membranes look complete. Any suspicion of missing pieces requires re-exploration of the uterus.
That covers standard MRP. But what about that third cause of retention, the morbidly adherent placenta accreta? That sounds like a completely different ballgame.
It is. Placenta accreta spectrum represents a failure of the normal boundary between the placenta and the uterine muscle.
What's the pathology? Why does it happen?
Normally, there's a layer called the decidua basalis and a fibrinoid layer, Niederbuch's layer, that forms a barrier, preventing the placental villi from invading the uterine muscle, myometrium. In accreta, this layer is absent or deficient, often due to previous uterine scarring, typically from C-sections or other surgery. So the placental villi anchor directly onto or invade into the myometrium itself.
And the risk increases dramatically with prior C-sections. Shockingly so. The sources provide stark figures. With placenta previa, placenta lowdown, but no prior C-section, the risk of accreta is maybe 3%.
Okay.
With placenta previa and 1 prior C-section, risk jumps to 11%. 2 priors, 40%. 4 or more prior C-sections with previa. The risk of accreta is a staggering 67%.
Wow. That really highlights why antenatal diagnosis with ultrasound or MRI is so vital in women with previous scars.
Absolutely critical for planning.
Can you clarify the different varieties of accreta based on depth?
Yes, there are 3 main types representing increasing depth of invasion. Placenta accreta is the mildest form. The villi are just abnormally adherent to the surface of the myometrium. Think of like wallpaper glued too strongly to the wall.
Okay.
Placenta accreta is where the villi are invaded into the muscle bundles of the myometrium, like nails hammered partway into the wall. And placenta accreta is the most severe. The villi penetrate through the entire thickness of the uterine muscle, reaching the outer serosal layer, and can even invade adjacent organs, most commonly the bladder, like a nail hammered all the way through the wall and sticking out the other side.
Accreta sounds terrifying, especially bladder invasion. How is accreta managed? It sounds like manual removal would be impossible or incredibly dangerous.
Attempting manual removal of a significantly adherent placenta, especially increta or procreta, is fraught with danger. It almost inevitably leads to uncontrollable, massive hemorrhage because there's no natural plane of cleavage. The sources state it has a near 100% chance of resulting in an emergency hysterectomy if attempted.
So what are the options if accreta is diagnosed or strongly suspected?
It presents a major management dilemma, balancing maternal safety with potential fertility preservation. For a woman who has completed her family, or if the accreta is extensive, total accreta, the safest and often necessary option is a planned cesarean hysterectomy. The baby is delivered via an incision high up on the uterus, avoiding the placenta, and then the entire uterus with the placenta still attached is removed.
But what if the woman strongly desires future fertility?
This is where conservative management might be considered, although it carries significant risks. The approach involves delivering the baby, cutting the umbilical cord flush with the placenta, and deliberately leaving the placenta entirely in situ within the uterus.
Leaving it inside, what happens then?
The hope is that the placenta will gradually resorb or autolyze, break down, over weeks or months. This is usually managed with close monitoring and often long-term antibiotics to prevent infection. However, it carries risks of delayed hemorrhage, infection, and may still ultimately require hysterectomy later.
Are there other treatments used alongside conservative management?
Yes. Sometimes uterine artery embolization is used shortly after delivery to reduce blood flow to the retained placenta and promote its involution. Methotrexate has also been tried, but its effectiveness is debated and carries its own risks. Conservative management is complex and should only be undertaken in specialist centers with robust protocols and patient counseling.
And if it's procreta invading the bladder?
That requires a highly specialized multidisciplinary surgical team, often involving urologists as well as obstetric surgeons. The procedure may involve not only hysterectomy but also partial cystectomy, removal of part of the bladder wall with subsequent bladder repair. It's a major pelvic surgery.
Okay, that's a deep dive into retained and adherent placenta. Let's cover the last of the big five complications. Uterine inversion. You said it's extremely rare.
Extremely rare, thankfully. The incidence is quoted around 1 in 20,000 deliveries. But when it happens, it's a life-threatening emergency.
What exactly is it?
It's when the uterus literally turns inside out, partially or completely, usually during or immediately after the third stage of labor. The top part of the uterus, the fundus, collapses down through the cervix.
Turning itself inside out like a sock. Are there different degrees?
Yes, typically described in 3 degrees. First degree, the fundus just dimples inwards but hasn't passed through the cervix. Second degree, the inverted fundus has passed through the cervix and lies within the vagina. Third degree, or complete inversion, the entire inverted uterus is visible outside the vulva.
What's the main danger with inversion? Is it hemorrhage?
Hemorrhage can certainly occur, but the most immediate and striking feature is often profound shock. And importantly, the degree of shock seems disproportionately severe compared to the amount of visible blood loss.
Why is the shock so profound? Is it neurogenic?
Exactly. It's primarily neurogenic shock. When the uterus inverts, it pulls on the ligaments that support it, particularly the broad ligaments and the infundibulopelvic ligaments. This stretching puts intense traction on the nerves and blood vessels within those ligaments, especially the parasympathetic nerves, and potentially pressure on the ovaries. This triggers a massive vagal response, leading to bradycardia, slow heart rate, and profound vasodilation, causing immediate and severe shock.
So managing the shock is paramount, but you also have to fix the inversion itself. How is it managed?
The absolute priority is urgent manual replacement. You need to try and push the uterus back into its normal position as quickly as possible. The sources stress attempting this immediately, even before anesthesia is fully available if necessary, though pain relief is crucial as soon as possible.
How do you manually replace it?
You grasp the inverted fundus, often with the palm of your hand and fingers spread, and apply steady, firm pressure upwards, aiming back along the axis of the vagina towards the umbilicus. The key is often to try and replace the part that inverted last. First, usually the parts around the cervix. Gentle, sustained pressure is needed.
What about the placenta? It's often still attached during an inversion, right?
Yes, frequently. And the general advice is not to remove the placenta before replacing the uterus.
Why not?
Because attempting to separate the placenta while the uterus is inverted can trigger even more massive hemorrhage from the poorly contracted muscle bed. The standard practice is to replace the uterus first, with the placenta still attached. Once the uterus is back in its correct position, you'd administer uterotonics to make it contract firmly And then you manually remove the placenta if it hasn't separated spontaneously. The only exception might be if a partially separated placenta is preventing replacement, but that's a judgment call.
Is there an alternative to manual replacement if it's difficult or the patient is in profound shock?
Yes, the hydrostatic method, often called O'Sullivan's method. This is sometimes preferred, especially if manual replacement fails or under anesthesia, as it can be less stimulating and potentially less shock-producing.
How does the hydrostatic method work?
It uses fluid pressure. Under anesthesia, with the patient often in Trendelenburg position, head down, you instill large volumes of warm, sterile saline solution, potentially up to 5 liters rapidly into the vagina, using a douche nozzle or similar setup. While instilling the fluid, the operator uses their hands or forearms to seal the vaginal opening, the introitus.
Creating a closed system.
Exactly. This builds up significant hydrostatic pressure within the distended vagina. That fluid pressure pushes gently and uniformly on the inverted fundus, gradually encouraging it to revert back through the cervix into its normal anatomical position. It's quite an elegant technique when it works.
Fascinating. So we've covered the big five. PPH with its 4 T's, retained placenta including accreta, shock, pulmonary embolism, briefly mentioned, and uterine inversion. That's a huge amount of critical information.
It really is.
Yeah.
And mastering this field, as we said at the start, truly requires understanding that whole continuum of care, from being hypervigilant with clinical assessment, using tools like the shock index and the rule of 30 to detect problems early.
To launching that rapid, simultaneous resuscitation during the golden hour.
And then having the knowledge and skill to escalate through those complex management pathways, whether it's the pharmacological steps for atony, the tamponade techniques, or the stepwise surgical devascularization procedures, right up to hysterectomy when necessary.
It emphasizes the need for not just individual skill, but incredible teamwork and system preparedness. Hitting those physiological targets, the hemoglobin, platelets, fibrinogen, requires a coordinated effort.
Absolutely. And achieving that highest level of professional mastery means being able to make those incredibly difficult, life-altering decisions under intense pressure. Thinking about the trade-offs, like managing total accreta, choosing between immediate, definitive hysterectomy versus that high-risk conservative approach to try and preserve fertility.
These aren't just clinical decisions, they're profound ethical and personal ones, too, made in moments of crisis.
Exactly. And they have to be executed flawlessly, often within that critical golden hour time frame. Which brings us to maybe a final thought for our listeners to reflect on.
Go ahead.
Thinking about your own setting, your own institution. What systemic preparations are truly in place? What specific training protocols, simulation exercises, readily available equipment, and clear multidisciplinary communication pathways exist to ensure that these complex critical decisions aren't just made correctly under pressure, but are actually executed effectively and rapidly every single time? Because ultimately, that level of system preparedness is the difference between controlled management and chaotic panic.